So, this is my rather cryptic title then for all of you. Oh, thank you. So, this is about auditory threshold estimation using the auditory steady-state response. What is the optimum protocol part 2? Now, I gave part 1 in the last Oticon seminar, and I'm just going to skip over a couple of points that came out of that and will become clear. So this really presents 2 MSc projects, which I presented last time, and a new one that was recently done this year. So just a quick recap then for the first few slides. What are auditory steady-state responses? Hopefully most people in the room are fairly familiar with them, so I won't spend too long on this. So they're an envelope following response, so they occur when the response becomes stable in terms of amplitude and phase relationships to the stimulus. So we put pure tone carriers in, and we modulate those pure tones at particular frequencies, and we detect the modulation frequency in the EEG if the tone's been detected. So here's a carrier inside there at a particular frequency, and it's been modulated, so we're changing its amplitude at a regular rate, 40 Hz in this particular case, and this is amplitude modulation, so the amplitude of the tone increases in a sinusoidal pattern at 40 Hz. And if that tone is detected by the auditory system, then 40 Hz pops up in the EEG. So it's a bit different from ABRs, which most people are more familiar with, in that some ASSRs, we look at the EEG in the frequency domain, not the time domain. So in ABR, we look across time, and we look at the amplitude of the waveforms following a time pattern. In ASSRs, we look at these frequency components. So here's a rather busy slide. It's taken from Gary Ronce's book that tries to explain ASSR, so I'll go through it very, very quickly because this could be a whole lecture in itself, I guess. Okay. So we take these modulated sinusoids and we put them in as an auditory stimulus, and we can test both ears at the same time, and we can test 4 frequencies in each ear at the same time too. So we can put in carriers at 500 Hz, 1000, 2000, 4000, so the audiometric frequencies we're interested in, and we can put them in both ears, and we apply a different modulation frequency to each of the tones. So it sounds a bit complicated in the way that it sounds like a nasty tone, but the brain is able to separate out these because of the tonicity of the cochlea. So each tone maximally excites a particular region of the cochlea, and if it's detected, the auditory system codes that, and we end up with a modulation frequency output. So for these ones here, if we put in these modulation frequencies here of 81, 86, 91 and 96, these different frequencies, and then we do some recording of the EEG like we normally do for ABRs and all other EEGs, we get a very complicated time waveform, but we convert that into a frequency waveform. So across here is frequency of the EEG, and then we're looking in the EEG at these particular places where we put the stimulus modulation rates in, and if these amplitudes pop up and are significantly greater than the noise using some statistical test, so NF test or a phase coherence test, that means the auditory stimulus was detected by the auditory system. And of course there's a bit of averaging like we do for other tests. So when we're doing threshold estimation, it's important to note that like all other EEGs, when we evoke potential responses rather to auditory stimuli, when we change the intensity of the signal, the amplitude we get out changes. So for very high intensity stimuli, we get strong amplitudes. And as we go down and down and down, closer to threshold, the response amplitudes become diminished. And that's quite important when we're trying to find the threshold estimation, because it means we need good recording conditions. So we need to be able to, for the ASSR, be able to detect that the signal is significantly above the noise. So if there's a high level of noise in the recording, then those small responses close to thresholds won't be detectable. So protocols exist for ASSRs, and there's been some recommendations made by the NHSP, the screening group, and they're not really a protocol, they're kind of a guidance at the moment, as more and more evidence is being suggested. And of course this is for infants. What I'm going to be talking about is more about adults actually, but there aren't really adult guidance necessarily. So we can manipulate different parameters when we're trying to find threshold and we're trying to detect the response. So we use these significance testing, and like all statistics tests, we get a p-value. So we can look for p less than 5, less than 2, less than 1. We can manipulate that, and that's something that I presented a little bit last time. And there's a lunch and learn seminar about that as well on the BSA website, which I did. So you can look at that if you're interested. And the protocols are recommended by the NHSP, say use the 2% criteria, and then we can use these stop when significant protocols. So unlike an ABR where we normally run a fixed number of repetitions and then another fixed number of repetitions and then compare them, in ASSRs we can stop the test earlier if it meets some statistical criteria, although that does change the percentages slightly in the statistics. That's the last presentation. So we can actually save a bit of time with this. So if the response is is much higher than the noise, say for a nice high level stimulus, then we can stop the test very early and we can be sure it's there. And as we get closer and closer to threshold, the amplitude diminishes, so we might need a bit longer for the response to appear significantly above noise, because in recording, as we increase recording time, the noise gradually averages away, and we'll see that in some slides a bit later. So they recommend a 4-minute recording time and then no recordable responses below a particular level to make sure you've got threshold, you found the lowest level you can detect, and P 2%. And something that's very important that they recommend is that you have a noise of less than 10 nanovolts in the recording. So we compare the amplitude of the response against the noise, and they're suggesting that if we have more than 10 nanovolts of noise, then you can't say that the response was absent. You have to say that it's inconclusive, because if it's more than 10 nanovolts of noise, then perhaps you wouldn't have got to threshold because you couldn't have detected the amplitude had it been there due to the noise. Does that kind of make sense? It's quite important. So what are factors that can affect how close you can get to threshold, how accurate a result you can get, and what kind of range do you get? Well, it should be obvious by now that we need to control the residual noise. If we've got high noise in the recording, we're not going to be able to detect these small responses close to threshold. And we can manipulate the noise by having a longer recording time. So the longer we record, generally speaking, the noise averages away, but we don't want to have a too long recording time because that risks the patient becoming restless and then the recording conditions get worse. And if they're asleep or awake, so if the patient's really nicely asleep and relaxed, the EEG noise is nice and low. If they're awake, it's much higher. And we can change the response amplitude as well. So there are, in the literature, there's lots of mentions to this. So we can change the modulation type, we can use different schemes, amplitude and frequency modulation individually or together, and we can use exponential modulation, which changes the shape of the modulation slightly. And again, for asleep or awake, so there's different ranges of ASSRs, 40 Hz and 80 Hz. One's better for awake, one's better for asleep. And then we can manipulate the statistical tests that we use and look for different percentages. And we can use stop and significant schemes, or we can use schemes where we require fixed recording time, or we require a combination of both where the response stays significant for a few averages to try and reduce the effects of false positives and false negatives that we might get. So we might miss the response when it was there, and we might accidentally say there is a response when there isn't one there, just purely down to chance. So we can improve these things. And as I mentioned before, there's an Auditory seminar where I talked a little bit about how we can manipulate the statistical parameters. But the most important thing we can look at is, again, is test time to decide how long we want to record. How long do we have to leave the recording going for to reach an acceptable noise level? How long would that take us? And so this is what I presented last time. So this is just to mention the effect of modulation rate. So these are some of the other factors that can affect the amplitude. So in the literature there's mention that each individual subject might have an optimum modulation rate that happens to produce the highest amplitude for that particular subject. And this study by Purcell and John, they found that. So what they did is that on the x-axis here they swept modulation rate and they looked at amplitude, and you can see that this individual happens to produce the strongest amplitude, the highest amplitude responses here and the lowest there, whereas this individual it's in a perhaps slightly different place, and the two lines represent repetitions. So for this subject it was fairly well repeated in two different recording sessions. So that might suggest that it would be worth spending a bit of time before you try and establish threshold to find out each subject's modulation transfer function, so that you know where the best amplitudes come from, so you can use that modulation rate in your stimuli. However, we did an MSc project on this, and we found that actually that wasn't really the case. So that Purcell and John study was, they had quite a long recording time, 20 to 30 minutes, and it was a swept stimulus, and it didn't really match what you would normally do in a threshold estimation protocol. So we tried to replicate what you more or less do for threshold estimation using 4-minute recordings. And although sometimes we did have the maximum modulation rates repeated in 2 recording sessions for each individuals, the general picture was that actually everything was a lot more variable than that, and so it wouldn't be worth spending the time trying to find the optimal modulation rate for each subject. So in this particular subject, we can see that the optimum rates were here, and that's here, there's a peak, and there's a sort of a peak here, and that's replicated across 2 recording sessions. But the general picture was, and this is looking at correlation between the 2 recordings, so on the x-axis, the best modulation rate in one session, and the y-axis, the other session, you can see that they don't really match particularly very well. In fact, they're often at the extremities, so not particularly useful to spend the time trying to find the modulation rate. So what about the effects of residual noise then? So perhaps modulation rate isn't something we need to look at, perhaps it doesn't really help us. So what about recognising signals in noise then? So we know that when you increase the intensity of the signal, the amplitude increases, and that's a normal hearing subject. But for sensory neural hearing loss subjects, of course, at the lower intensities there is no response because they can't hear it, their auditory system's diminished in some way. But we get this rapid growth of amplitude for sensory, with the subjects with sensory neural hearing loss. It's a bit like kind of the recruitment phenomenon. So very close to threshold, we can get much higher amplitudes than we could for normal hearing subjects. So that presents a bit of a problem. It means that for someone with a hearing loss, it's easier to get closer to threshold because the amplitudes are higher. But someone without a hearing loss, it's trickier to get close to threshold. And of course, when we're doing hearing screening, we want to find out if someone's got a hearing loss or not. So it's kind of important to know that. So here's a normal hearing subject, and this is a high noise recording here. So this dotted line here represents the noise. So anything below that, we couldn't detect because it's below the noise. So we end up with the threshold here. So this is a match between ASSR threshold and behavioural threshold. So we end up with a very high ASSR threshold when their behavioural thresholds is quite low, simply because there's too much noise in the recording and those amplitudes are too small for us to detect. And of course this applies to everything else, ABR too, the same principles apply actually. But for a sensory neural hearing loss person, we get this rapid growth in amplitude close to threshold, so it's much closer to the true the match line there, simply because of the rapid growth of amplitude. So we think that for sensory neural hearing loss patients, we can get closer to the threshold, but for people with normal hearing, we can't. And when we're doing threshold estimation, we want to, as I said, be able to find people who've got normal hearing just as much as we want to be able to find people who haven't got normal hearing. Okay. So there are some mentions in the literature of other studies that have looked at the effect of recording time, which is what I'm going to focus on now. And so this study here, which is Rance and Rickards, they had very short recording times of only 90 seconds, up to 90 seconds. So if it was significant, they stopped. If it wasn't significant, they carried on 90 seconds to see if it arrived at significance or not. And you can see that that represents the sort of noisy situation where the thresholds are a little bit raised compared to behavioural thresholds. Although actually these were infants, and they were very young infants, so the noise conditions were pretty good in those recordings because they were sleeping, sleeping neonates. So that's a good recording condition anyway. And then Dimitrovic did this study on adults, and they recorded up to 17.5 minutes for each recording, so that's a pretty long time. And in fact, they found that it took about 15 minutes for the noise to reach 10 nanovolts, whereas in the baby protocol, we wanted to reach 10 nanovolts after about 4 minutes. So you can already see the difference in noise conditions. And these were kind of resting, relaxed adults. And you can see that there's a reasonably good match, but again, it's not ideal. There's still quite a big range. So if you took an ASSR threshold here, there's quite a big range of thresholds that it could have been. It's not bad, but we'd like it a bit better if possible. And this study doesn't really tell us, we can't analyse it over different recording times and produce some inferences about what the best recording time might be. So what we did with Cargill's MSc project this year, so Cargill Brandon, we decided to do an experiment where we'd look at the effect of recording time and what threshold we might get. So we took 10 normal hearing subjects, so thresholds better than 20 dBHL, and we did fixed length recordings of 12 minutes at, with multiple ASSR, so we had 4 frequencies in each ear, all within the 80 Hz range. And we did 45 sweeps, 12 minutes, and we did it at 5 different levels in HL, fixed levels, regardless of what their actual PTA thresholds were. And we kind of stopped at 40 because we hoped that we'd get a threshold at 40, at least for all of them with normal hearing. That wasn't the case, actually. And also, if you're using a screening threshold test, you'd probably stop around 30 or 40 for a kind of screening. So that gives us a bit of information about whether we can detect normal hearing or not. And we did that for 2 test sessions. And then we did an offline analysis multiple time points in these 45 sweeps. So what we did is we applied a threshold criteria. So we'd say, is there a response at the higher level? Yes, keep going down until you end up with where there's no response, and then the one above that was threshold. And we did that for multiple recording times across the full-length recording window. So we'd say, if you stop the recording at 15 sweeps, what's significant reach there? And then 17, 23, and so forth until you got to 45. So allowing it to run to 45 sweeps for a recording to pop up. And of course, the longer the recording, the less the noise was. So there was a greater chance of the small responses closer to threshold appearing. So here's just some examples of the data. So here on the x-axis is sweep, and the y-axis is the amplitude in nanovolts, and the darker line there, that's the amplitude of the response, and the dotted line here, that's the noise. So you can see that as the recording time increases, noise diminishes, but it's an inverse square law rule, so you get diminishing benefit as the time increases. And then this other line here shows the significance. So in this recording it took, so if we were using the 2% criteria, it took about 15 sweeps to reach significance. But down here, it never reaches significance at 10 dBHL, so the threshold would have been taken as 20 for this subject. But that depends on test time, because after 15 sweeps here, we didn't have a response at 20 significant, but after 25 sweeps, we did. So you can already see that as you increase the recording time, you end up with a slightly lower threshold. So now let's look at noise levels. So the NHSP guidance says we want to have 10 nanovolts or less, otherwise it's not a good recording condition and the results are inconclusive. So we looked at noise across recording times, and this is percentage of recording. So this is 800 data points, because there's 2 subjects twice, 5 levels, and 4 in each ear. And we can see that if we want to have, and this is cumulative numbers of data points less than that noise level. So for example, if we wanted to have a 10 nanovolt noise level for 45 sweeps, 80% of them would be accepted as response absent, whereas 20% would be inconclusive even at 45 sweeps. And if we use the same protocol for the babies of only 15 sweeps, 4 minutes of recording time, less than 20% of our recordings would be considered as being a conclusive result, and 80% would be inconclusive. So clearly, these protocols for babies can't really be applied to adults, because the recording conditions are different. There's more noise. The adults don't tend to fall into a deep sleep necessarily, or at least they didn't in our studies, and no studies I've ever run has had that happening. And we can just look at the effect across different times as well. You can see where the benefit is. So really what we're saying is to have 80% as a conclusive result, we have to change, so 45 sweeps, we've got 10 nanovolts, and we have to use 20 nanovolts for 15 sweeps. And if we're using a higher noise acceptability criterion, then that means that we're going to have responses that are further away from our actual threshold, because there's more noise and we're not being able to detect those small thresholds. So let's have a look at what happened to the thresholds then with recording time. So each of these boxes represent the frequency, and this is all of the data from the 2 sessions from all of the subjects. And we can see there's kind of a downward trend of threshold across recording time, so allowing only 15 sweeps, and then 21, 27, so forth until we get to 45. As we get to 45 sweeps, the threshold, we get a kind of downward trend of getting closer to the threshold, which is what we'd expect, because there's less noise. Okay? And it's a similar picture for 2 kilohertz, but the lower frequencies, they look fairly similar. And the range of frequencies of thresholds you'd expect for 15 sweeps is quite large, and it does get a bit narrower as you increase, so there's a bit less variability, which represents the lower noise. Oh, and I should mention these thresholds are converted to sensation level. So here's that data again, just with some numbers, which you can look at later if you want. So I also analysed what the recording time would have actually been. So if the responses, if all the responses in the recording were significant sooner, we could skip that and not require it running to the full 15 or the full 45. But if only one of the points in the recording weren't significant, we'd have to carry on until it was, or till the full test time. So that's how we get into recording times. So we can see that how the thresholds change. So for 4 kilohertz, we changed from a mean threshold of 21 to a mean of 11, and the range from -5 to 50, from 5 to 25, and that would require a change from 16 minutes on average to 51 minutes on average, ranging up to the full 20 minutes or the full 60 minutes of recording for those different times. So we did a statistical comparison, because we like doing statistical comparisons. So we looked at the first recording, 15 sweeps, and the second recording, 45 sweeps. And these are the mean differences in thresholds. So, and we found that for 2 kHz and 4 kHz, we had a mean difference, a mean improvement of 16 and 12 dB in threshold, and these were significant, but these lower frequencies weren't. So even by increasing the test times to 45 sweeps, changing from 15 minutes up to an hour, we didn't get much closer or significantly closer. Notice how the numbers are diminished, because we didn't get thresholds for quite a lot of subjects at different recording times. So we couldn't make comparisons when the threshold wasn't even reached at 40. So this here shows you the numbers of times when we had to throw it away. So even 50% of the time, the 15 sweeps, we couldn't get a threshold at 40 even. And even with the 45 sweep recordings, we still couldn't get a threshold at 40 dB HL for 70% of the time. So that shows us that we need to go up to 50 or more HL to get thresholds and ASSRs. Now the recording that I did in my PhD, I did lots of super recordings. So I used about 60 and I was getting quite good responses. So I suspect if we'd just gone up by 10 dB, we'd probably capture most of these people, but that's a best guess. And this is supported in the literature as well. There's other tables in different textbooks and CATs that show that what the mean thresholds are, and there's quite a big standard deviation, so you expect quite a big range. But one thing that's key about all the literature is that no one really agrees on what protocols to use, what stimulus to use, and what recording times to use, so it's a bit variable. Okay, so what can we conclude? So I've mentioned this already, most of this. So quite a lot of the time, we couldn't even get a threshold in normal hearing subjects at 40 dB HL. At worst, 30% for 45 sweeps and 50% for 15 sweeps, 50% of recording points, that is. And the noise levels, 80% reached 10 nanovolts or less at 45 sweeps, but 20% at 15, only 20% at 15 sweeps. So if we took a 10 nanovolt requirement, we only had 15 sweeps, then we'd be throwing away all our recordings. So clearly that isn't long enough for adults. And it took 36 minutes of extra time to get significant mean improvement of about 15 dB for those two frequencies, but at other frequencies the improvement wasn't significant. So this is all a preliminary analysis. We need to look at this data a bit more to find out, in those kind of 20% of the top range there, was it just that the recording conditions were very poor for those subjects? Were they not well relaxed? So we can go back and look at those noise levels, noise in those recordings, and see what they're like, and see if they're outside the range. And it could also be, we also know that response amplitudes are quite variable between and within subjects between sessions as well. I found that in previous literature, so that's something to look at as well. And so we can also analyse the repeatability of amplitudes and noise across all these recordings. So there's a lot more to do to this data yet. And that's about what I have to say about that today. Are there any questions?
Tim, so the standard deviation around these estimates was of the order of 10 dB or plus or minus 10
Yeah,
dB.
10, 20, something like that. Which is about the same in the rest of the literature.
And not that dissimilar to ADR though?
Yes, actually. So
although it doesn't look great, we have to remember that ADR is not that much better, right?
There's a lot,
especially at low frequencies.
That's very true, and there's a lot of criticism to ASSRs about this kind of thing, and because there's a lot of research going into this. If you really look at ABRs, it's the same problem. It's trying to do threshold estimation in ABRs in adults doesn't work very well either. So that's a clear point. Perhaps we shouldn't be using ASSR or ABRs. We've got better tests. We've got corticals, right? Corticals give us nice big amplitudes, so let's use those. Good point.
Well, I wasn't recommending we use corticals actually, because I was looking at data recently about the presence of a cortical for different sensation levels, and actually on normal hearing kids, there was a huge number that didn't have a cortical at 20 dB sensation level. So I think it might not, it will depend on the recording condition, of course.
And that's what's key in the literature. The recording conditions aren't always clearly reported, and the method of finding threshold isn't always clearly reported, and there's no agreement in ASSR studies. So in ASSRs, of course, we've got 40 Hz as well, which do give higher amplitudes, but it's still nowhere near what you get from a cortical. So signal to noise ratio, or the response amplitude to EEG noise ratio, is much poorer for all of these tests compared to doing cortical responses.
So just because Kai's next to me,
yeah.
the data I was looking at was for awake babies. I don't know what would happen if they were asleep.
Okay.
But normal hearing,
yeah.
about 40% didn't have a response 20 dB above their estimated behavioural threshold.
Yeah.
But would you say that that is very much the case with children? When it comes to adults, I would say that corticals are much more robust.
Yes.
If they are sort of, if everything is normal in
Indeed.
their auditory pathway, that's very important.
So really, we should be careful about trying to use them for threshold estimation, certainly. And if we're doing super threshold tests in adults, we might be okay. But if we're trying to do other tests that are close to the threshold, then we should be thinking, well, maybe the signal to noise response to the noise ratios aren't as good as we'd want to do those tests.
And when it comes to sleep, I think that is very, very interesting, because in general the idea is that you shouldn't do corticals in sleep. But in very young babies, where the sort of quality of sleep is completely different from slightly older children, you can actually get corticals in active sleep.
It might not all be down to noise. It could be that some subjects just don't have very high amplitudes. There is some variability, so those ones we couldn't get the thresholds, it might just be that their amplitudes on. It might not be in the recording conditions, it might just be that subject.
That would be really important to try to find out, because otherwise we're just scratching our heads.
And I can certainly look at that. I just finished looking at some of this yesterday. So.
And do you also know whether these subjects actually have an absolutely healthy auditory
That's an interesting point. I mean, we checked standard audiometry, but we didn't do any kind of any other psychoacoustic tests, like frequency difference alignments or anything else, intensity difference alignments, nothing. So you're right.
It would be really interesting.
It could be something interesting.
Yeah, because if it's just a technical thing or a noise thing, then it's kind of boring.
Yeah.
But it may be
something interesting.
It's actually,
I mean, in some of the work that I did, so I didn't record the states of cardio, in some of the work that I recorded, I noticed a few subjects who didn't seem to have high amplitude, so I think people like that exist. But again, as I said before, that even when you repeat in the same subject, there's quite a lot of variability of amplitudes, actually, for the same subject.
That is really disturbing.
And well, it could be something to do with what their physical state is, because we know that for 80 Hz range, some of the response also comes from the cortex a little bit. And if you look at Terry Picton's book, he explains this, how there's a kind of an overlap, and the reason why you get that shape is because the interactions between the two, sort of in and out of phase, cortex and brainstem. So it could just be simply that if they fall asleep, something happens, and if they wake up a little bit, then something happens. So it could actually represent the different amount of how actually they are in that recording. That could be it. It could be a change of state. I don't know. People are trying to look at that a little bit.
Are your electrode configurations, what are those?
So it's vertex, just below the hairline, so that's active preference, what doesn't really matter for ASSR, which I only put it, and clavicle for ground.
Right.
Which is one of the standard.
So it could be that
it could be
for different modulation rates you've got a different best montage for electrodes.
It's possible.
Do you know if anybody's looked at
there is a paper that looks at electrode montage, and it's a long time ago I read that, so I can't exactly remember.
I know Dave Parker started looking at that many years ago.
There is a little bit of literature on that, yeah.
But if you've got more than one source, it may be that certain modulation rates, different montages give better.
I mean, it could be also
results.
Slightly inaccurate vertex placement. I mean, that can make a difference.
So just to make sure I understand this, Richard. So when we do ABRs, we get maximum amplitude somewhere on the midline, and the same with corticals. So doesn't that mean as long as we're in the midline, we're in the right place, or for any of these modulation ones? Or
isn't it the rationale that it's sort of aligned with the brainstem or something? But it's interesting. I'm not really sure actually.
But I was just thinking, if you've got more than one source that's interacting, it
You're
may
right.
be that at some positions you're getting less interaction than at others.
That could be a factor, yeah. But it might be. But then that could change according to state as well. So you want to record from multiple electrodes and then change the electrodes according to what they're doing. But you could do that.
Yeah.
But you'd have to have a big, cap for doing threshold estimation in adults, which I don't think would go.
not in 4 minutes.
Yeah. It wouldn't be clinically good, would it?
Okay, thanks to both our speakers today, and thanks to